Hi, my name is Shannon Gray, and this is my HEENT assessment with Patrick Williams. We've already performed the Rosenbaum and the Snellen test, and Patrick's vision without corrective lenses is 20/60, meaning that he can see at 20 feet what somebody could see that has normal vision or good vision at 60 feet. So when I walk into the room, I'm going to just do a quick inspection to make sure we don't have any involuntary facial movements, to make sure we have symmetry, to make sure the contour of the skull is within normal limits, and then I'll have you take off your glasses. And at this point, I'm just going to palpate the frontal and the maxillary sinuses for any pain, tenderness, swelling.
No.
Okay. And then at that point, we're going to go ahead and move to just inspecting the eyebrows a little bit further and the eyelashes to make sure that we have an even distribution, extension, we don't have any crest, and then also looking at that orbital region to make sure that we don't have any swelling, any redness, any drainage from that, and then also looking at that sclera for same and making sure that it's white, that we don't have any yellow tinge or jaundice appearance. And then I'm going to have you go ahead and look straight up, checking that conjunctiva, which is pink and moist. We want to make sure that it's not pale, meaning that we could have signs of dehydration. And then I'm going to go ahead and get a light source. And with this, I'm just going to obliquely turn this on. So we're going to look at the lens and the pupil, looking at the light obliquely and looking for symmetry from one side to the next and color differences. So we might see at this point that there may be slightly, and then also making sure that the pupil responds to the light appropriately, which Pat's does. And then also while we're here, I'm going to go ahead and check to make sure that they're equally round and reactive to the light and consensual. So we know that we're equally round and reactive. And then with that consensual light, making sure it's not too bright, we're going to shine that light into Pat's left eye to begin with. I'm going to have you look straight ahead. And with that, what I'm looking for is his left pupil to react, which it did, and then going back in again to make sure that right pupil constricts. And then coming on to the other side, making sure that that side constricts. And then again, going back in, making sure that the left eye constricts, which his do. Now I'm going to check the visual fields, starting with the peripheral vision. This is done by the confrontation. So getting close to the patient, again, it might be a little bit different when they're at my level, but I'm going to move my hands, and you tell me, go ahead and look at my nose, and then tell me when you can see my fingers.
Yep.
Okay, and then again.
Yes.
Okay. So his peripheral vision is intact, and then we're going to go ahead and change to the sixth cardinal's gaze. And I'm going to have you not move your head and follow my finger with your eyes only. So moving laterally to his left, up, down, back to that lateral position, then midline, and then to his right, up, down, lateral, and back to midline. And then I will have you go ahead and just follow my finger in towards your nose. Perfect. So with that, we're going to make sure that the pupils constrict as I go in and that we don't have any extraocular eye movements when we're doing that, and to make sure that the eyes don't bounce. Next, I'm going to go ahead and get to the fundoscopic exam. And with the fundoscopic exam, I'm going to have you look forward, and I'm going to be checking for that red reflex. I'm also going to be following in the pupil at this point to make sure that we can see the blood vessels, the optic disc, moving intranasal to check the macula and the fovea. So since I'm checking Pat's right side, I'm going to have the scope in my right hand, my left I can see that red reflex, and then moving in to see the anterior chamber, and then again moving to his left side. So I'm going to hold the scope in my left hand, my right thumb on the eyebrow. You can visualize that red reflex, and then moving in Perfect. So again, we just want to make sure that we pay close attention to that. And then now we're going to do the ear exam. And first I'm just going to do the tug test, so making sure pulling kind of up and back and down on that pinna, checking for any tenderness, pain.
No.
Okay. And then again, the other side.
No.
Okay. And then we always want to use the largest speculum possible. So looking at that tympanogram, that tympanic membrane, for adults we want to pull the ear up and back. And then also looking for that light reflex. So with the tympanic membrane, we're looking for a pearly gray or a pearly white color, which Patrick's left side is, and then also same with the right. We want to make sure we don't have any bulging, redness, any tenderness when we look inside that ear. And then next we are going to go ahead and do the hearing test. So we're going to start with the whisper test. I'm going to have you go ahead and cover your right ear. And normally I would stand a little bit further back behind the patient. I'm going to whisper to you. Tell me when I say.
Baseball.
Okay. And then coming to the other side.
Basketball.
Perfect. And then now we're going to check for bone conduction and air conduction. So starting with the Weber test, we're going to strike this and tell me which ear you hear it in.
Both.
Okay. Tell me when it stops.
Stopped.
Okay. And then next we're going to do the written test, and again we strike this. We're going to put it on the mastoid bone, and then we're going to move it in front of the ear. So tell me when you can no longer hear.
Stopped. Stopped.
Perfect. So what we anticipate on that is that the bone conduction is less than the air conduction. So the patient should be able to hear it longer in front of the ear versus on that mastoid bone. So again, we're going to do it on the other side.
Stopped. Stopped.
Perfect. So now I'm going to move to the nose, and I'm going to get my light source out again. And I'm going to have you flex your neck just slightly so I can go ahead and inspect for drainage, symmetry, and then looking at the mucosa, which should be slightly pink, and the turbinates, looking for any polyps, abnormal drainage, the septum alignment. So I'll have you go ahead and look up. Good. And then I'll go ahead and have you open up your mouth and move to that eye exam again, or I'm sorry, the mouth exam. So again, we're going to inspect. I'll have you say ah.
Ah.
And that lets us look at the tonsils, the uvula, which should be midline, the pillars. And then also we want to go ahead and inspect inside the mouth further and look at that hard palate and also the mucosal areas. And again, if I had a glove on, I would go ahead and further palpate in, and then I'll have you lift up your tongue. And then we want to check underneath for the ducts, and then on each side laterally, we also want to make sure that we get a good inspection there. And then I'll have you pull down your lip. And that helps us to be able to see also if the patient is missing any teeth or if there's any other abnormalities within the mouth. And then lastly, I'm going to look at the neck, starting with the trachea to make sure it's midline, checking for masses, lesions that we might see, palpating the neck starting with the preauricular, postauricular, tonsillar, submandibular, submental, and then checking the occiput. And then at that point, I'm going to go ahead and move on down to the postcervical, supraclavicle, And basically what I'm checking for there is to make sure that we don't feel any lymph nodes, and if we do, they should be pea-sized, they should be movable, they shouldn't be tender necessarily, and if they are hard, tender, then at that point that would warrant further investigation and possible referral. And this concludes my HEENT assessment. Thank you.